uh, you are more than welcome, right? Can't really do medical questions in a personal level, uh, but I do get quite of those as well, right? I prefer not to because I don't know your medical records and things like that, but I get personal questions all the time, all day long. And if I can be of any assistant to you, regardless of what it is, I'm always happy to do so. All right, last one because it just came to mind, okay? About timing of the course. Don't worry about timing, okay? This is not like, oh, you can only attend once. Oh, I mean, I put a limit to where the system will shut down. Otherwise, it will become impossible to update people and things like that. But if your account gets shut down and you need more time, I will never charge you again. Okay. But that could work against you, right? Because now we have a relaxing environment. So I wanted to find a happy medium that is good for you, but does not set you back, right? And that's a dangerous one because when, as humans, when we don't have a deadline, you'll be like, okay, I'll do it tomorrow. And I don't want this to happen. But if things happen, life happens, divorce, a new boyfriend, new girlfriend, housing, whatever the situation is, life, right? If you need more time, you will never get charged for me, ever. Whatever all you have to say, hey, Dr. Lopes, I need more time, and I'll give it to you. Okay. So it's not, this is very different than any other course that will rip you off and try to take every single dollar out of you. I would appreciate your support, but not really my main drive. Okay. Not saying it's not, hey, I'm not a cent and it's not everything is free all the time because I have to support uh my employees, but it's not my main drive. Okay. It's not why I wake up at 6 o'clock in the morning. It's not when somebody calls me and says, hey, can you please meet with me because I'm testing? If I can get up at 4 o'clock in the morning, I will get up, and you will never hear and don't offer either any money because it's not what I'm exactly doing, not from my heart and not my intentions either. So uh, do it because you are important. I do it because if you are asking, is because you think you need it. And then if I can do something, even if it's last minute, even if it's 4 o'clock in the morning, I will do it. But then, I'm restrained on time as well. Okay. But final message is don't worry about time. It's not a 30 days. We try to support you for six months. Need more time? Never will be a problem. If you needed to be here for a year with me, be here with a year. If you want, so your colleagues during school, oh, I don't want to do it because it's too early. Well, not quite. You guys know the time flies, right? And it's like, okay. Anyways, just want to enforce that time is not my thing. I'm here for you. So let's get started with today's event. And today it's what I call the easy hanging fruit. Well, what is that? That club? What's the easy hanging fruit? Well, it's one of those that you will miss if you are not in a course. Why would that be? Well, because these things like cases, court cases, we don't talk about those in school. I don't care where you went. uh Ethical principle, very basic but can be very confusing, right? uh Few of the topics today you won't encounter in a specialized course because the specialized courses, they are there to pass the board, not necessarily to teach you how to be a psychiatric nurse practitioner, although that is my ultimate goal, is to get you there as proficient as possible. Uh, and it is easy to miss if you don't have the prior knowledge of it, but it's easy to get those points if you attend today's class and if you work through those questions and principles as we learned today. Okay, 1 second, please. All right. So the first one is practice versus standard of practice. This is the first topic that we'll be covering today. Then we'll talk about confidentiality, the airsoft principle in court cases. Will be tons of questions on court cases. You're likely to get about 6-7 questions out of that. So it would be super smart of you to really take the time now to memorize those cases. Informed consent, ethical principles, researches, health policy, patient advocacy, culture. You will get tons of questions on those three subjects. Quality improvement, and finally, we'll close off with patient-centered model and the social determinants of health. Okay, so this is not a super long class, but again, we'll take frequent breaks, make sure everybody is on point and completely understand the subject. All right. Question number 1, you will get this question, no doubt, one way or another, and often try to confuse you the difference between scope of practice versus standard of practice. So what is the difference? When do we say this scope of practice, right? Generally speaking, excuse me, is used by national and state licensing board for various professions, not just nurse. That defines the procedures, actions, and process that are permitted for a licensed individual. So that's the scope of practice, okay? Not only for nursing or psychiatric nurse practitioner. Okay, so let's take a look here. The scope of practice, who determines that? The state. Is it ANA? No. The scope of practice determined by the state that you live. California has very distinct scope of practice, right? So it's the statute board of nursing. So questions could have been, who determines the scope of practice? The answers could be state legislature or the statute state board of nursing, right? Scope of practice for nurse practitioner is the nurse practitioner roles and actions and defines competency assumed to be held by all of us who function in the role. So first thing, scope, state. What do they do? Roles and actions of what we can and cannot do. So the board varies and often due to outdated legislation, right? And supporting the scope of practice displays leadership. So we have several package questions that could come out of here. One is the definition of scope of practice, and then you should write down by the state defines roles and action. That's it, right? And outdated due to different legislations by the state. You should look at that and be able to say 5 little things by the state, roles and actions, and outdated law. That's all you really need to remember. Now, the second portion of it is how do you support the state board of nursing, or how do you display leadership, right? So the second question, by doing what? Advocacy through professional involvement and joining relevant organization. I've seen this question come up many times, right? In different books, different roles. How do you display leadership? Joining a professional organization like who? ANA or other organizations. Okay? But keep in mind We're talking about here the scope of practice. So let's see how it is different than the standard of practice, right? So in this case here, if a medical evaluation is out of the scope, we already know what the scope of practice, what is necessary to happen, how someone determines if my practice out of scope. Well, I'm the hospital director, and I'll say, I would like, recently I had to do this, right? So we involved all the leadership and said, hey, let's collaborate to determine if this is within the scope of this social worker, socialized, oh my God, licensed social worker, right? Advanced practice. Let's take a look on what she's doing. So we're doing interprofessional collaboration to see if they meet or not the scope of practice. Here, obviously, is about the PMHNP, right? So how do we know if they are working within the scope? Hospitals usually do an interprofessional collaboration to ensure the patients are safe. Okay. Now, fourth question possibly here is who sets the minimum standard for NPs? Remember, here's about the scope. And if it's about the scope, who sets the minimum standard? The board of nurse and the state. Okay. Here, answers that require contacting the state board of nursing are often correct. It makes sense. But when the question comes on the test, it does not make sense. Why would I call the state board of nursing? That's not realistic. I don't have the time. They never answer the phone. But now, if we look back at what we learned, we can see that it kind of makes sense if we want to dial down to the perfect environment with all the assistants. The patients have more than enough time to wait for an answer, right? So, hey, State of California, we would like to know if this law is applicable here or if I am within or without the scope of practice. Okay, so scope states I don't know the answer, or I need to know what's the minimum to meet my scope of practice. I call the board nursing, uh, the board of nursing for the state. Okay, if the answer requires you to report to a colleague or supervisor, are often incorrect because it's not addressing directly the patient or the problem. It's more about telling on someone. Okay. State laws and Nurse Practice Act, it's what's determined under the state. Under the state means the scope, minimal required competency or scope for the state. And this is different again between every state. Are we very, very clear on the scope? I know it's a lot. So all you need to do is put a scope of practice, and then you write down 3, 4 reminders that anchor your memory to what you learned. Because if you try to write down the whole paragraph, it becomes too much, right? So one way to remember, you can call it DSLAM, DSLAM, right? Determined by the state legislature, right? The S is who, is the scope. The L is the variation from state to state. The A is the advocacy. How do you display advocacy? The I is for the interpersonal collaboration. And who sets the minimum requirement is the board of nursing for the state. So we cover determine, the scope, legislation, advocates, interpersonal, and determined by the minimum is the But the minimum set scope is by the state. Now, how they will try to confuse you is by putting phrases of in the answer choice of the standard. So the scope is think of this, the standard is above, is a higher arc. And from the standard, we have our 50 states there, and each one will say, you're saying they can do X, Y, and Z, but here in Alaska, I would like you to only do this. So the standard is the bigger umbrella from which the state draws what they can and cannot do. Example, the standard says you can work independently, and the scope will say not here in California or X, Y, and Z. So if the standard is the big umbrella, it's determined by who? ANA, American Nurse Association. Okay, so what do? Well, they'll put up a paper. It's called the authoritative statement regarding the quality and type of practice that should be provided. They will not go in extremely detail because there is the blank statement, and the scope by the state will determine what you can and cannot do in that state. So why do they do that? Well, because it provides a way to judge the nature of care provided. And that's important. Why again? Because it's legally described what is the standard of care. Now here, they can never compare you to a social worker or to a psychiatrist or a psychologist. Although those disciplines falls under mental health, we do things differently by the standard of practice. Each one of them do things differently. So the law requires the PMHNP to carry out care, provide care per reasonable, prudent criteria that other nurses would do in a similar situation. Let's say you broke the standard practice, but you did because you were under fire. People are shooting at you. So in that situation, it would be very different than taking care of a patient in your office, right? So does providing high quality care are consistent with established standard? Established standard is critical, right? So highlights here is the standard of practice by whom? ANA. Why? Because establish a nature, a way to judge you of what care should look like. And again, can take you to court to say, hey, you did follow the standard or you did not. Comparing one-to-one, meaning PMHNP, what versus other PMHNP. So if the question compares you to anybody else, that would be incorrect. So the standard of care is the quality of care. Where does the MP Code of Ethics come from? Again, ANA. Okay, actually two different things, but the same organization. Two questions about ANA you need to know. The standard of practice comes from ANA. And who does the nurse practitioner codes of ethics come from? This is nurse practitioner, ANA. Okay. Where does the MP Code of Ethics come from? Now here should have been PMHNP. Take a note of that, right? So here then it would say there's American Psychiatric Nurse Association, or APNA, or ANA in this case. Okay. All right, so are we clear between the scope versus the standard? and those nuances that are often indirectly associated with those two terminology. Any questions? Go
Yes, I
ahead,
have
please.
a question.
Unmute yourself. I cannot see you. Okay, sorry.
Yeah, I have a question. I see, where does the NP code of ethics come from? And it says ANA. Then it said, where does the NP code of ethics come
Yeah,
for
this
P?
was sort of a more PMHNP, more specialized. Here, there is a high involvement of American Psychiatric Nurse Association or ANA, really, because let's say that the American Psychiatric Nurse Association is a sub-unit of the bigger unit. The bigger unit would be APNA, all right? The bigger unit, well, let me rephrase that. So if you, ANA would do nurse practitioners. Nurse practitioners are divided in several smaller specialties. So the answer could be either ANA or the American Psychiatric Nurse Practitioner, but they should never be both at the same time. Does that make sense now?
Hmm.
Or no?
I think you're reading the question, the bullet wrong. I'm not sure what your name is, but if you read what he wrote, he just kind of wrote it quick. So if you read it, it says, where does the NP code of ethics come from for us PMHNPs? He's telling you it comes from the American Psychiatric Nurse Association. And then he was saying, or the ANA for NPs, for everybody.
Oh, for everybody. And then
Yes.
there's a separate one for
Yes.
a psychiatric nurse practitioner.
Yes. Yes.
Right. So what does it mean? Thank you for a different way of putting and clarifying. Thank you very much.
Sorry,
So what I'm
guys.
saying is that question answer, it could
Yeah.
really say ANA. Would that be incorrect? No. Would that be incorrect if it said APNA? No, it would not be incorrect. But the answer should never be both in an answer choice, ANA versus APNA. It's like saying, where do you document suicidality? And the answers can be two. Where do you document suicidality? Anyone?
Content, thought content, thought content,
Not content or
or
MSN.
MSE, right? Mental status examination. Now, it really shouldn't be the mental status examination or the other option because both are correct. But if you are going to pick more specific, then you would not pick the MSE, mental status examination. Does that make sense? So
Yes.
it's different ways of saying the same thing,
Okay, it makes sense.
or
Thank you.
kind of like, okay, let me see if you really understood the concept or you memorized what somebody said, you verbatim, right? It's like, okay, let me go a little bit deeper on this and ask the same question a different way to see if you really understood. Or you just went to the books, whatever they said, you memorized it, and now you're here to test that out. Okay, so we cover very specific examples of scope and the standard. And because it's S's all over the place, it can be confusing at times. So I really want you to digest this, write a little things about each one of them. And then when you look at it in the morning, be able to scope, say it, standard, say it to yourself, and repeat it several times. Okay? So now, again, we use an acronym for scope. Now for standard, we can say GJPLC. So it's determined by, again, American Nurse Association. This is the standard, bigger umbrella, which is ANA. Y is the J. It's a way to judge you. They're comparing you against someone else that would have reasonable same skills in the same situation. because the P is for the protocol, the standard of care can be legally described. And we gave an example, PMHNP versus PMHNP. The law is the L, can carry out per reasonable, prudent criteria, and is consistent, right? So providing high quality care consistent with established standards. All right. So if you have a better acronym, go ahead and put in a checkbox so that others can learn, and I can learn from that as well. And maybe I'll add it to this slide next time if it's a better one. So I have met many of super smart students, and now PMHNP, or some of them are about to become, and some of them have better acronyms, and I would love to steal them from you if you allow me, and then pass it on to others, right? If you have a better one, please go ahead and write it down in the chat box, and we can go over to. Okay, so just to recall, difference between scope of practice versus the standard. Nursing scope of practice determined by the state. Now, here, I mentioned this before, is held close to the Nurse Practice Act authorization, right? For nurses within that state. So different ways of answers of the same thing. Question about the scope. Answer could be the Nurse Practice Act authorization. Oh, that law beside the state. Yes, that comes from a law from the state that borrows from there, and the bigger state determines, the nursing board of the state is determined, but it's drawing from the Nurse Practice Act authorization, right? Nurse Practice Act, not authorization, okay? They authorized for the nurse what they can and cannot do in that state. Now, bigger umbrella, who? The standard. By whom? ANA. They are related concept, very close. Is the standard practice describe how the task is within the scope of practice should be performed. Because it's related, it can be confusing, and I don't want you to miss a easy question. Kindly, someone could read this question for me, please. Any volunteer?
I can go ahead.
Thank you.
Okay. A court evaluating the standard of care provided by a PMHNP would primarily prioritize the following. A, holding them to the same standard as a psychiatrist, regardless of their training and scope of practice. B, comparing their action to the established prevailing professional practice of a competent psychiatric mental health nurse practitioner in similar situation. C, the judgment is based solely on patient satisfaction surveys and feedback. D, scrutinizing the PMHNP's patient chart for inconsistencies with past treatment decision. So the answer would be, you want me to say?
Yes, please.
B, comparing their action to the established prevailing professional practice of a competent psychiatric mental health nurse practitioner in similar situation.
Thank you, Sunny. So as a practice, always read the question to yourself. You don't have to do it, when you're reading the question here, but as you practice the question bank, it's like, read the question. Do not look at the answers. Tell yourself, what is the core of the question? What is the question's asking? Okay, in few words, is asking me about the standard of care. Immediately in your brain, you go, who does the standard of care? Is this the standard of care, right? Provided by a PMHNP. And then you kind of would formulate that answer in your head without looking at the answers. And now you read through the answers. And the one that matches what you said will never be the same is likely to be the answer. If you practice that, it seems like a long process, right? Terribly long. But the more you practice, you'll be surprised that you get all the questions right, that you know what the material. The trap is not to get sucked in by nuances or reading too much into the question. When you match the answer in your brain, you'll be surprised how much you know. Okay. So he is asking for the standard. So comparing the action to establish prevailing professional practice of a competent PMHNP in a similar situation, right? So consider what's reasonable, prudent the PMHNP would do in a similar situation. All right. So where should a NP find the most up-to-date information on their state specific scope of practice? So it says, hey, core of the question, where do I go to look at my state scope of practice? Okay, scope, I remember, is determined by the state. It determines what I can do or not in that state. Option A, do I go for professional association website? Do I go to online NP forum? Do I go to the state board of nursing website, national NP certification organization? So when I did the core of the question, I said, hey, I remember that the scope is from the state and it sets specific scope of practice. And then as I'm reading the answers, it tells me that the state board of nursing website. So it matches roughly what I was thinking before I saw the answer. And that should be the answer, right? I'm going to validate, look at options A through D, and I should get the right answer, right? Roughly, I said, it comes from the state. The answer was look at the state nursing board of nursing for my state website, providing the information that I'm looking for. And the more you do this way, is one way of doing, is not the best or the only way, is one way that I practice all the time for answering every question for a long, long time. So it works super well for me. So if it works for you, please adopt it. Says the NP scope of practice is the state board of nursing website. You can go there and you can figure out what it is that you can do in that state. Now, if you wanted to look what is the standard, then you'd go to ANA website and be like, hey, what is, generally speaking, what I can do in this profession, right? All right, it's a lot of similarities and can be a bit confused. Is anybody stuck on what we covered just a minute ago? Guys, if you are unclear, that means somebody else is unclear. So do yourself in the favor for your friend and for the others that are here. Don't understand, let me know. I'll try to repeat it in a different way. If it's not a bother for you, I'll stay over after the class is over. And I'll peel this problem in different ways so that it's helpful to be helpful to you, okay? Now, scope, state. Now we are going to confidentiality. Promise you, you will get a question on confidentiality, okay? Because it protects patients and also hold us accountable. First question that you might get is one of the patient's rights. One of them, patient has the right to confidentiality. Why? Because it assumes the information given to the provider will not be disclosed. Oh, guys, I had that. Joanne, 27 years old, X, Y, and Z, that came in my office crying, right? Now, as a provider, I can share that I had a patient that came to my office. She was crying, distress, X, Y, and Z, but I did not disclose who. Very different, right? When we put a patient's information that can tie them, we are breaking up confidentiality. So very important, patient has the right to more than one right, and we're going to cover the three main ones. Number one, patient has the right to confidentiality. Super important, because that might be a question. It requires provider to obtain a medical authorization and consent form to release medical records and information when requested by the family members or another healthcare. So here comes the question that we always get. If your husband and wife calls and asks information about you, would you, as a nurse answering the phone, would you give it or not?
No.
Right? No. Even though it's the husband or the wife or the daughter, it's most likely the patient would say, yes, of course, my wife, it's my husband. But we have to ask. That can be a formal and informal way, right? Preferably, we always want the formal way with paperwork signed and say, hey, this, we can talk to those folks, right? But don't fall into the overthink. Oh, yeah, a question says, hey, he's married for 30 years, living happily after ever, and have, this beautiful life, and everything works out. Now he has cancer, and he would like to discuss with his wife. His wife calls on the phone. So it prompts you all the beautiful things that the answer would be yes. But then if the question says patient has not signed informed consent or verbally authorized just yet, he's thinking about it, then the answer would be no, right? So, for example, releasing patient information to the pharmacy requires consent. That's a hard one because we can think or overthink on what's written. Oh, I never see my provider sending a informed consent. I'm sorry. Never seen my provider sending the information to the pharmacy requiring patient's consent for that, right? But you can read this question and say, is the pharmacy in my hospital? Or is it the pharmacy at the end of my state in the Walgreens that the patient lives close to, right? So what's important? Don't read into the question. It never said this is in a hospital or outside the hospital. It said to the pharmacy. So that is a break of confidentiality. Okay. So HIPAA does not allow PMHNP to make most disclosure to disclose psychotherapy notes for patients' conditions without their authorization. Now, two separate release forms are necessary to what? For cases that involve SUDC, substance use, and psychiatry. So what does it mean? My patient is alcoholic and has major depressive disorder. How many consents do I need? 2. Okay, recap. This alone could be, this small slide could be 3 questions. One of the patient's right. What is it? Confidentiality. 2 is, pay attention to this. Release information to the pharmacy. It is a break of confidentiality. Question number 3, how many consents or do you need if the patient has a substance use disorder and a mental health anxiety? Let's say anxiety, right? Answer 1, 2, 3, and 4, right? And like question 175. You could easily miss this question, but now you know 2 consents are needed. And we'll go back to the pharmacy in just a minute because we're going to read a very similar question. I already screamed out of my lungs, and some of you guys might miss the question. We just cover, but let's see how the test makes it tricky. And it's not all about knowledge, it's about application. Okay, so confidentiality, and I even warned you guys that some of you guys will miss. And if you do, let's talk about it. What must be signed before any healthcare in the state is provided in the state, right? Here is the notice of privacy practice statement, right? Because the privacy rules provides that an individual has the right to adequate notice of how a covered entity may use and disclose the protected health information as his or her right and covered entities obligations concerning that information. So now the question very likely to be is what must be signed before anything is provided? The patient must sign the notice of privacy practice statement because that it tells what is the provider's obligation to the individual and what's the individual right and how the entity will cover their personal information and protect them. The rules for HIPAA, well, applies to emails as well as two-way encrypted communication. So if you Google Gmail, your hospital, and say, send it back to me, and they say, yeah, no problem, sign this form. And then you sign the form and send it to the hospital. And the hospital says, yes, here I'm going to send you a link. You click on the link, reset your password, and I will upload your file into this portal that is two-way encrypted. How many of you guys have gone through this process in different ways? Anything that's even taxes sometimes with my CPA that lives in the United States, I send it to him, he is protected, right? So it's not only nursing. So what is the purpose of HIPAA? Is it only to protect the patients? No, it's a national standard for healthcare electronic transactions. It's a identification for who? You. It identifies you nationally, right? It's the health plans and employers, not only confidentiality of the patient. It's an identification for the provider, and it covers the bigger concerns that everyone has, which is what happens if my medical record is stolen, right? So it provides one, provider ID, two, electronic health records, and three is the confidentiality. So HIPAA has how many purpose? One is ID, two is the electronic health records, and three is the confidentiality of what's disclosed in the medical record. All right, one way to remember and recap, this one's kind of hard, right? RTDPENEC. Was read panic, right? So the R is for the right of the patients to assume the information will not be disclosed. The T here would be the transfer. The transfer, the providers must obtain consent to release medical records. The D is for the disclosures. The HIPAA restrict disclosure of psychotherapy notes without authorization. P for psychochemicals, how many? Two. We need two authorizations to release some information for a patient with mental health disorder, MDD, major depressive disorder, I'm sorry, generalized anxiety disorder, and opioid use. If it's the same patient, we need two separate authorizations, right? And emails has to be encrypted before it's released. All
Dr.
right.
Lopez,
Yes, please.
on that last one, read panic just wasn't sticking in my head, so I rewrote it for myself, and it was a good idea because it stuck. That was it. I
Go ahead.
used never eat red tomatoes during picnic, Chief.
Okay. So please write that on. I like that one better than mine for sure. It's easier to say. So please write that down in the Google Chat meeting so the others can see it and actually get it. I like that one better than the one that created. And
I like
if you
silly.
allow me, I'll steal it
Sticks
for
in the
sure.
mind. When it's
Mhm.
silly, it's just easier.
Yeah, creating acronyms, it takes a long time, right? We have to look at the stuff and be like, how can it be said better, different way? So as I always say it, the most inappropriate ways and the wrong ways are usually the best way. Whoa, Dr. Lopes, how could you say that? Well, things that are inappropriate and all the time incorrect are the things that we remember. Oh, I remember what you said. What I said so many things throughout the year, but you're gonna remember one thing because it was inappropriate, right? It was a confusion. People remember things. Now, not to say this in public, right? You keep it to your head. Never say it in public.
Can
But
you please say the mnemonic one more time, please?
yeah, she's gonna write down in the chat box there.
I
So
sent
it
it on
helps.
WhatsApp. Yes, I sent it on WhatsApp. Never
Okay.
eat red tomatoes during picnic, Chief.
All right. So I see a lot of hands, and I'm not always looking at the Google screen. So if you have a question, please stop me. So I probably skipped some folks. Okay, so I do apologize that.
Dr.
So go ahead.
Okay, okay. So I just want to make sure I'm clear. So the two forms that we need is authorization to release information and informed consent. Both
Yeah,
for each patient.
yeah, but the two types of form is that you need different informed consent is what the provider will do with the patient. That's one thing. But the release of medical records, you need two of them, right? Because it involves two types of because anytime there is a SADS involvement, it requires a release of information, informed consent, a release of information. Okay.
Mhm.
And then if it has a mental health disorder, it requires another one. Now, informed consent is between I and you, the patient. Hey, this is what's going to happen here and here and here.
Okay.
They're kind of similar, but distinct in the same time.
Okay.
Okay.
Dr. Lopez, I have a couple of questions because
Please.
I got lost. I got lost when you said that you have to have a release of patient information to send to pharmacy. So are you saying to send a prescription above and beyond the HIPAA privacy practice statement? I have to get a consent form to just, read medication and send it to pharmacy. I got lost there with that concept.
Yes, and I love that you asked the question because you certainly would likely to miss this question. And I mean, I love when people ask because we can clarify. So the question saying that I have you coming in as a patient and I have done the consent here, right? Say, hey, this is X, Y, and Z. That's what I will do. These are the medication. But in order to release my prescription, so it usually goes like this. Once you sign the paper, you have authorized it within my organization. Okay, you said, hey, you can release it here. Now the patient will say, hey, I would like to get my prescription at the Walgreens in North Carolina, right? So you have to get a release authorization to release the medical records to the pharmacy. Okay, so yes, you are right, but the question that the linkage here that you might be confused because it's so odd is that the pharmacy is not within your institution, and therefore it needs a release of it needs a release of medical records for the institution that you are providing the patient's record. I think that's the linkage that's very confusing.
And is that in addition to that HIPAA privacy policy that's signed at the beginning of services where it's
Yeah,
just
because that one is that's within my organization. We sign all the paperwork, everything is good. Now you say later, hey, I would like my medication to go to the Walgreens. That's a different institution. So you have to say, hey, here's the release of information to send to the Walgreens. Because if you don't, what law have you just broken?
HIPAA?
Okay, don't answer that because that's the question that we'll see in a second.
because I've not seen this at all in my clinical rotation.
Exactly.
Yes.
You don't see that ever. And because one, it's all under the rug, and two, most of the times that get seen by you gets, it gets their medication from the hospital that they're being serviced. No, we don't see that. And that is the key difference, practice versus a perfect world where everything is followed, every dots are crossed, and all the T's are crossed and everything is done by the book. So this is a task environment, right? It's like the basics, everything works, everything is fine, right? So basically, all what it's saying is don't break confidentiality. Don't release the patient information to the pharmacy without authorization.
I have one more question before you move on.
Please go ahead.
I only counted one form of the release of information. I wrote down, when you said release it to pharmacy, what's the other one? You said there's two.
Okay, so let's go back here a little bit more. Before you even see a provider, right? An admin, the desk, they'll give you what? They'll give the notice of a privacy practice statement, right?
Mm-hmm.
Because this is the front desk person, because this will say, hey, your privacy rule provides rules that provides that an individual has the right to what? The notice of how this entity will cover the protection of your documentation. And you're like, okay, no problem. I see how it works. So before any care provided, the person in the front desk will give you this privacy practice statement. Now you walk in and you come see me. Now I'm going to do informed consent, right? We're going to say, hey, these are your options. These are the things and so forth and so on. Just like you do for
A procedure.
for surgery and so forth. They are related, but one goes more in details and one is more like, hey, this is your documentation. This is how we're going to use and things like that nature. Okay, so I would highly encourage, if that's a bit confusing, to write those terminology and then read those up a little bit more in detail, because it kind of, it could go in the nuances of things. Okay.
Okay, so those are the two forms.
Yeah.
Okay.
I mean, many hospitals will add other things, but these are the main ones for sure.
Okay. Thank you.
Right? Okay.
Dr.
So,
Lewis,
go ahead.
On the two separate releases of information required for dual diagnosis for patient's chemical and psychiatric condition, can you, let's say we have a patient that's actively suicidal, they have substance use disorder, and they have major depressive disorder, and we're going to send them to the hospital, whether it's voluntary or not. Are you saying when we send them to that inpatient facility and we release some information so that they'll be in the know of what that patient's treatment has been, we've got to have two different documents signed to send that dual diagnosis information? Is that what you're saying there?
Yes, and very close, and no, because if the patient is within my institution, right? I'm the outpatient clinic. I'm in Boston, big hospital, let's say. Then we don't need that because it's already signed within. Now, the patient is being released or sent to another hospital. Yes, exactly what I'm saying to you. So it boils down to one simple thing, one simple line. Be careful, everyone, not to read too much into it. It boils down to how many forms, consent of release forms do you need for psychiatric and the side disorder? Two, release of information. But it is exactly what you said, right? So let's say I'm an outside clinic, I have my own practice, patient suicidal, schizophrenic, major depressive disorder with SUDS. You will need to be admitted at this moment. Now I'm going to need at this point, so that actually brings another question. If the patient is not able to give consent, would you send it or would you not send it? Yes, because it covers what I'm about to cover, how is not a breach of confidentiality. In that case, the patient is dangerous to himself and others and is not able to provide a conscious decision. Now, if the patient is alcoholic and major depressive disorder and will need to be admitted for withdrawals or what have you, now I will need two separate consent. One is for, hey, this is saying that you are using alcohol, and this is saying you have major depressive disorder. Are we super clear?
Yeah, it's clear, but I mean, it covers a large portion of the population.
It does, yeah.
Yeah.
But
Okay.
because later the patient can go back and say, hey, my release of authorization says I released you that you can talk about my mental health disorder, major depressive disorder specifically, but I would never like the hospital to know about substance use disorder, and you broke my confidentiality.
Yeah.
Okay. Now, this is very in the books. In practice, questionable. And it may happen, but because there's so much in the books, and that's more the admin, the management portion that deals with that, and not so much they'll come to you and say, hey, here's the release information. One is for this, one for this. You sign it, your day goes on. You didn't even think about it. You read it to release information, you signed it. You may not have time to process all this, the reasons why. Okay. So you want to break the confidentiality. Sometimes you don't want to, but you have to. So breach of confidentiality, how does it happen? So it's a disclosure of the information to a third party without the patient consent. Hey, you released the patient with alcohol and major depressive disorder. You only got one consent. You just had a breach of confidentiality. Patient information can only be released with patient consents in writing or verbal. Remember, I said, hey, John, can you tell me if it's okay to give this information to your wife? John says yes. Good for now. After that, I got my paperwork and, hey, here, sign it, please. Thank you. Prefer in writing, but can be verbal. We don't like verbal, but they can be. And HIPAA considers the release of authorization without authorization only to facilities, treatment, or healthcare operations, right? I'm sorry, let me go back. HIPAA considers the release without authorization only to facility treatments or healthcare operations. So we'll go back what that means, right? We'll go back on that because it's important. It's going to be in the breach or exceptions. So can you release without the consent? Yes, it depends when it's appropriate. So you have to judge, back to the case of a schizophrenic, highly suicidal patient with alcohol use disorder. Patient is not able to sign a consent. But here, I'm going to break the confidentiality because it outweighs the risk, right? So the information release outweighs the risk of the principle of confidentiality. Break it. That's number one. Oh, well, guess what? It has a number two into the same example. It has the intent to harm self or others. Break the confidentiality. Third case that I can break confidentiality, judge says, hey, I need this paperwork. Subcomponents or summers. Break the confidentiality. Now, attorney comes to you and says, I need this information. Break the confidentiality. Insurance company, this one gets a lot of people. Why? Well, they have to pay for it. How are they going to pay if they don't know? So that's not a really break of confidentiality. It's already in written in the document of the release of consent. So, hey, this is X, Y, Z. Now, people ask the same question. What if I'm paying out of pocket and the insurance company wants this? Then it will be a no, because they don't have the right to know or the need to know. Okay. Now, some states may require that certain conditions be mandatory reported. In that case, you can break the confidentiality, such as in case of child, elderly, and abuse. You have to ask the abuser, hey, I'm sorry, but I'm going to have to break the confidentiality. No, right? I cannot think of any other mental health condition right from the top of my head that you would break the confidentiality. But the exceptions here, child and elderly. So you need to know when they outweighs the risk. 2, harm to self or other. 3, court orders. You don't have to go like subcomponents, assumers, that implies. 4, a attorney. We are not going to get in the details whether it's in the defense or whatever type of attorney. If the question says attorney and they ask you for document, give it. Number 5, insurance. Number 6, mandatory reporting. You need to know all 6, yes. But you should be able to not memorize it, but go like, okay, number 1, outweighs the risk. Number 2, intends to self-harm. Number 3, court orders. Number 4, attorneys, or you can put that in court orders. Insurance and state requirements. Okay? If you want to put all this in a mnemonic, you can call it ethics. E for emergency, T for the threat, H for the hearing of the court order, subcomponents, summers. I for the insurance. I can tell you so many times I hear the questions with insurance. Do you release the information? Yes, you do. And the C is the condition meeting the state's requirement. Just you need to rephrase it so you kind of go back to what you learned. And S for the safety in case of child abuse and elderly. Okay, ethics is not necessarily directly to what we learned, but it kind of anchors your memory back to what we learned. Again, you remember GJPLC, right? That we covered by the American Nurse Association. And that is the state of the scope.
What?
Standard.
Remember that we learned GJPLC.
Yes.
This acronym is determined by the state or the standard, a scope or standard?
Standard.
Standard. Okay. Just a recap.
I
Go ahead,
have a
please.
question on the ethics. You
Okay.
mentioned child or elder abuse. Would there ever be a time when you'd have to make an exception for spousal abuse? Would it be
Always.
okay? Approved?
I don't care about the spouse. I don't care, and I want you to be rude, and I want you to remember. Obviously, I care a lot. It hurts me. I might go to the bathroom and cry. But
Right.
I want you to know, like, hey, Dr. Locke said, I don't care about the husband. Why?
Right.
Well, one, if you report, you're in the wrong. Unless if your state says you have to. Why? Well, they are an adult and they have choices. They may want to report, they may not. You reported my husband, now he's in jail, and now I don't have anyone to pay my rent, and I'm super unhappy. They're gonna sue you. You
That's
thought
why
it
I
was the
thought
right
I
thing.
asked the question, because that's not as clear cut as elder and child. You could get sued in a heartbeat, and you're just trying to protect her. But best intentions won't matter.
Nope. Only elderly and child. I will oftentimes I'll tell my clients, hey, would you like to report this? We can provide you safety, shelter, and we can protect you. But I cannot assume, as soon as the client leaves, hey, I'm going to call the police and say X, Y, and Z, he's beating her up, right? Thank you for the question, because it's shocking, to say the least, right? I would love to pick up the phone and report it right away,
Right.
but I can't. I may just have to take a deep breather, go outside, and go back, and go back to see someone else. Can someone please read this question for me?
Dr. Lopez, I have a question.
Please.
Okay, I just want to be, so for the purpose of having an evidence-based practice, right? With the informed consent. So basically, if I'm writing a prescription, basically I have to have the patient sign release of information. Is that what you're saying? And also when
Yeah.
I'm collaborating with a doctor as well?
Yes. So you're
Do we have-
collaborating.
Uh-huh.
That's usually implied that if it's within the same organization, we will collaborate. That's part of the informed consent is already done.
Primary
Now,
doctor.
you need this information. The patient needs a ECT, and you talk to the patient says yes. Now, you don't provide ECT, so you're going to send it to another organization. Now you need a separate consent for the organization.
Consent or authorize both authorization to
Both,
release.
yeah.
So
Authorization and consent, correct.
So we can use a generalized authorization to release. I have to keep, each time I
Yes.
write a prescription, I have to get an authorization to release because I've never seen that done.
Yes, because now you're going to release the information to a different organization, right? You're going to say, hey, I would highly recommend this treatment. Would you be willing to do it? And if you do it in a different hospital or different state, here's the paperwork that says the release of information that you have to sign it. And then I can make the referral and release the information if appropriate.
And one more question, Dr. Lopez. So basically with the app, because they have several apps, I'm just talking, I know this is not within our, but with the different medical apps that they do have now, where a lot of providers, psychiatric mental health nurse or psychiatrists are using, is it in there? The release authorization was used to release the medication to pharmacy. Is it automatically in there already?
Yeah, usually yes. Generally speaking, because we are dealing with our organization circle, right? And the organization circle can be very big. If I work for this organization, my meds will go to this pharmacy that under the same umbrella. What we're trying to do for tests is, and the questions will not say it, whether it's within your organization or outside. So in that case, you need to know that consent has been signed.
The patient pharmacy.
It's confusing, guys, I know.
It's a lot.
But what we need to do is not read into the question. Keep it basics as I'm providing to you, the basics of it, and go with that. And then match what the question says. Okay? Can someone please read this question?
I will, Dr. Lopez. The psychiatric mental health nurse practitioner has provided a patient's medical records to her husband, as the patient has authorized him to access them. In doing so, the psychiatric mental health nurse practitioner has followed the principles of a therapeutic relationship. A, non-malfeasance, B, beneficence, C, confidentiality, and D, empathy. It's, may I answer? C, confidentiality.
All right. Excellent. Thank you for that. Now, since I got you, Jessica, let's go back for number A. What is number A? And can you give me an example of how would that be applicable? If you know. If not, call on anybody on the line and ask them for help.
I'm going to take a stab at it.
Please.
So, non-malfeasance is Let me think about that for a second.
Tina, please.
Do no harm.
Sorry. No, just let her think, please, everyone.
He's always got me.
Yeah, think about,
Yeah,
So
and let her think,
basically,
everyone, please.
Sure.
basically the
Trazodone?
Mute your mic if you're not Jessica, please. Go ahead, Jessica.
So non-malfeasance is essentially do no harm to the patient.
Beautiful. Yes.
So thinking of an example within what's going to be our practice,
Yes.
I would say that you would take the most precautions with a patient and to make the
Okay.
best decisions so that you do no harm, whether it means that the patient may be placed under a Baker Act, like for example in Florida, that if that needs to be the case, then you would do that, but always be keeping in mind that you would do no harm.
Perfect. Okay, so I love what you said, Jessica. I could not have said it better. But on task questions, how we would come up is withholding a medication that could be detrimental for the patient. Let's say, talking about substance abuse. Last week, I had one of our previous students that came out, hey, Dr. Lopez, I have this clinic in Florida. I do a lot of substance abuse. I am in a bind here because now I have someone with opioid use disorder and he has ADHD. What do I do? I said, based on the principle, therapeutic principle of non-maleficence, you would hold the ADHD medication. Well, that's a preference. This is what I would do. This would be my backup here. Under this principle, I do not want to I do not want to risk your health and my license over the ADHD. We'll try to manage that with non-stimulant basis. Basically, the risk of providing a stimulant could be more harmful than providing the treatment for ADHD. We can go in this in details, and you are more than welcome to go ahead and provide your stimulant. You're not wrong either. There is no right or wrong. But if I'm going to withhold, I would say, based on the principle of non-maleficence, statistics reports that a high numbers of patients that this medication has a high number of abuse. The patient has a history of opioid abuse and could be detrimental to his health. Could, not saying it is, because some people would say, hey, he actually doing this because he has ADHD and can't get ahead in life. So there's an argument for both sides. Same thing is the principle of beneficence, which is doing good. So you do not withhold the medication that could possibly do good. For example, SSRIs for major depressive disorder. So, but I want you to key it in, like to really focus on a non-maleficence, because the questions will come in this order. Another example, anybody can give me an example of non-maleficence?
I've got one.
Trazodone.
You're
Trazodone.
treating an ADHD child and they come back for their follow-up and their whole world has changed. Their mother is just ecstatic and bouncing up and down. The child is ecstatic, has changed their whole life. And you realize watching the child, he has developed a tic and you have to stop the med. And she is not happy.
Okay.
And if she's litigious, she might even try to sue, but based on non-maleficence, you're doing the right thing.
Okay, beautiful example, very likely to be on your test. So you stop the medication because of the stimulant. What is that the medication that often comes up with non-maleficence?
Trazodone.
Trazodone. Why? What does it
Priapism.
do?
Patient
does it
can
do?
patient can develop a priapism. So
Okay, priapism, which is a erections that happens for a long time without stimulation, right? And it is a side effect of what medication again?
Trazodone.
Trazodone. So basically, on this principle, if you get a question that says patient develop priapism, which is 1 in 10,000, I believe, very low chance, by the way, but it's something that I always like to talk about because I see in the books, don't see this very much in practice. I am withholding non-maleficence medication, based on this principle. Okay, enough of that. Let's go on to the next rationale. So confidentiality is the place, is the paramount in patient-provider relationship, even with their consent, sharing patient information should only happen for specific reasons, right? I shouldn't go on Facebook and talk about my patient with specific examples. Should only happen for specific reasons, aligned with the patient benefits and with clear communication about the information is being shared and why. All right, so here is a good question. Let me see if this is one. All right, someone kindly read this question. Any volunteer, please?
I'll try.
Mm-hmm.
A patient with depression discloses thoughts of harming themselves during a therapy session. Which of the following actions best protects confidentiality while ensuring patient safety? A, keeping the information confidential and offering further therapy sessions. B, reporting the suicidal thoughts to appropriate authorities. C, discussing the thoughts only with the supervisor for guidance. Or D, sharing the information with the patient's family members anonymously. Okay, let me think about it.
So first thing is to ask yourself, what's the question? What's the core of the question? And then, if possible, create an answer and then look through the answer choices.
Okay. Well, the patient, they have depression and they basically told you that they have thoughts of harming themselves, and you need to figure out which is the best way to protect their confidentiality and safety.
Okay, so now we have a dangerous situation
Mm-hmm.
and we want to protect confidentiality and patient safety. Then we should be like, without looking at the answers, something should be screaming break of confidentiality without looking at the answer. Maybe or not, I'm not even looking at the answers choice, right?
Mm-hmm.
Because there is a safety issues and you still want to protect confidentiality, but you have a dilemma in your hand between confidentiality versus patient safety, right? So first thing that pop out of my mind would be a break of confidentiality. And then I would look for something along those lines. I don't know. I haven't looked at the answer. Now I'm looking at the answers, right?
Mm-hmm.
But go ahead. What would you pick?
I would not pick D.
Okay, so eliminate the. Okay.
I would not do A because that's like you didn't do anything. I'm stuck between B and C, but I don't know. Like with only the supervisor, that doesn't make sense. I'll just say B, but yeah, I'll just say B.
Anybody disagree?
I disagree.
Okay. All right. Which letter would you pick?
B.
And why?
Because the question asks you about protecting confidentiality while ensuring patient safety, and the only way to ensure that with suicidal ideations is
All
to
right.
report.
So I see where you're going. And the question maybe could have been better written. I agree. But again, you are super smart, but you get in the nitty-gritties, okay? But the question could be better written. So you're really reading what the question says, and you are right as far as protecting patient confidentiality should decide verse or while ensuring patient safety, right? But still, I mean, even the way it's reading, it really, do you think that B, a C, or what letter would you pick then? Would be stronger than B? Even the way you are reading, what letter would be stronger than B and why?
Stronger than B.
Right, yeah, because you said disagree, so you got to pick a different answer than B.
Well, I didn't think she picked B.
Oh, okay, so you actually agree then.
Yeah, I agree. I'm sorry.
Okay, no problem. Guys, we have to troubleshoot the way we think. In order to learn a different way, we have to troubleshoot the way we think. That's cognitive behavior therapy in a nutshell for students, right? So we break those down, although the question can be a bit confusing, and guess what? They will be super muddy on the test. I don't make it super confusing on purpose here. It will be more confusing on the test. So I have to get you accustomed to feeling uncomfortable and not giving you enough information. Because if you would, all of you guys would get 100% if I give you all the information you need.
Wait,
I will never do that for you. Never.
What was the answer?
While confidentiality is important, the duty to protect the patient's life supersedes in such a case. So reporting suicidal ideation while the patient understands minimal risks and promotes safety while respecting autonomy. So let's go back here.
It's
So,
B. I said B.
B. Yeah.
Yes.
Oh,
yeah,
hold
and
on.
I disagree.
Hold on.
But I agree.
I'm sorry. I said, I'm so sorry. I didn't say, oh, yeah. Oh, yeah. I'm thinking of B, but reading A. So I'm sorry. So reporting the suicidal thoughts to appropriate authorities, right?
Yeah, that's what I said.
Yeah. So here could be a better answer too, right? If it said, hey, this is a suicide thoughts with plan and intention on the question. But even with those unclear answers, the best answer would be B. Okay? Think back. If you find yourself in an urge to fight those questions, think of yourself one principle that we learned in nursing school, which is, which one is the best answers of all answers, right? Something along those lines. We all heard this. Yeah, answer B is correct, but the answer A is the best overall answer. And unfortunately, it kind of applies to us, right? All the time. You most likely have a correct answer and the best answer in the same question. So when there's not scientifically foundations, right? Because that in that case, it can only be one, right? All right, can I have a volunteer here?
Dr. Lopez, I have a question.
Please.
That question to me doesn't really make too much sense. And the reason for me to say that is because I thought when you have a homicidal ideation, you do report to the police. But when it's per se, when it's to that person, I thought you want to admit them to the hospital or something.
Yeah,
Really?
no, you do. It's always, they always come in the same phrase on the learning that we did today. Like break up confidentiality. What did I say? I said, hey, when there is harm to self or others, right?
Well, that
So
question
we
didn't
said
say
this on the
police, it
break up
said authorities.
confidentiality here somewhere. Anytime the patient says to me, I have a plan in reality, and I'm thinking of doing it, you cannot even take that back. No, I take that back, and I was joking. Sorry. Can't take it back. I heard it. And then we may never see each other again. But in that case, that will be what I need to do to protect you and protect me. Okay? So it's not one of those cases that we say, well, you know, the patient took back, and if he said it, you heard it, you can be right 99% of the time. That's like 99.9. So you've seen 1,000 patients, but you've been wrong a 0.001 time. That is enough to take it away, everything that you have done for the last 30 years, and to have been in your conscious. So I'd rather be wrong 99.999% of the time by being right one time, right? Because I'm caution in the name of safety, right? So that's one that we have. Hey man, if I heard it, if I have those gut feelings, I'm gonna do it because I really don't care if I'm wrong. The wrong, it's like someone coming to the ED and they have all the signs and symptoms of a GERD, but they actually having a heart attack, and I miss that. I don't care if you have GERD. I can miss GERD all day long. You can go talk to your primary care provider and figure that out. But I'm going to rule out, I'm going to take my EKG, I'm going to collect my labs, I'm going to put you in oxygen, I'm going to put your head elevated, I'm going to do all the precautions until I can prove this is not a heart attack. I can care less about GERD, but I need to prove what's going to kill the patient. That's my job if I work in AD, is to discern what's emergent and versus what not. The what's not, you go back to primary and you figure that out, right? It's like, hey, doesn't look like a cellulitis with extra blah blah blah. Patient's released, right? Or heart attack or other indications, and that's why it takes a long time. Anyways, so a therapy observe a patient
Sorry,
exhibiting.
quick question while we're on that
Sure.
note. For test-taking purposes, if the question was worded differently and they had said the patient, presents with chronic SI, would you still report it to the authorities or just provide psychotherapy and let it be?
I think the question will give you a little bit more.
Okay.
Right? Yeah, I think the question will give you a little bit more. So, because chronic, that means is not acute. Not acute means what the patient lives on a regular day, right? So we can make the case of not necessarily reporting if there is nothing else in the question that it would say this patient is a chronic suicidal. Now with the plan, completely change the way the answer might be. Would you agree with that?
Yes, that makes sense. Thank you.
So
Yes.
sometimes a lot of this stuff that we're providing, you got to take in face value and don't extrapolate. It's good that you're thinking live and it's good that everybody's kind of working, oh, what I see, but be careful not to go too deep. Go 1 or 2 levels deep, but don't go super deep because that's not usually, that's a state, that's usually a hospital policy. This is how you know to do things because that's what you've been doing. Okay. So a therapist observes a patient exhibiting signs of child abuse during a session. What is your next action? Ooh, this one will get so many people. A, report the patient's family member. Let's say there was it was a family member doing that. So I'm going to report the patient's family member. Only if the patient confirms the abuser. Reports to the appropriate child protective agencies regardless of the patient's wishes. D, report only if the abuse is ongoing and severe. So if I see somebody just ripping a child's arm and violently, right? That would be the scenario, something along those cases. Then C, that's what you said, or B?
C.
Report to CPS.
Okay. Now I want you to warn you. This is super easy, but how it can be difficult. A child reports to you that he has been abused. Now, answer A, I would put, answer A, I would put immediately report to CPS because most of you guys would pick that. So that would be a distraction. Answer B, collect more information about the incident, if possible, without the abuser first.
Yeah,
Would you still pick A instead of B?
No, we need to let more info.
No, right? So this is the dilemma that I see for many years. The people that are report to CPS. No, you have critical thinking. You have a master's degree or doctor's degree. Your first job is to collect the information. If the possibility is not in the option, then you do what the MSA would do, the medical officer. I mean, the person in the front desk. Anyone will pick up the phone and report to CPS. But you have critical thinking skills. Collect the information if you can without the abuser present, right? So that the child is not in harm. So here we're protecting the child first to begin with. If the child is with me, the child is first. 2, I'm using my degree and role to protect the child and collect more information and find out more. And then 3 would be to report. So don't fall in the trap of calling CPS immediately, only when the alternatives are not appropriate, like collecting more information with the patient or whatever might be the case, right? So in this case, it's a mandatory reporting. So yes, absolutely going to report that. Okay, guys. So we actually did a lot here. It's been a while. So let's go ahead and take a 10-minute break.
So-
10 minutes good for everyone?
Was the answer C?
Yes,
that
it was report. Correct.
Okay, because it says confirm with the patient. If you got a 5-year-old, you're not necessarily going to be able to confirm with a small child.
Well,
There's a lot of variables because it wasn't stated like that to collect more information.
yeah,
That's
no,
all-
no,
That,
I'm
that
saying,
one already
I'm saying,
told
yeah,
you observed
I'm
sign.
saying a
But
similar
in that
question.
particular question, those specific answers, the correct answer was C.
Correct.
So I'm not crazy.
So what I'm
C
saying
crazy.
is that when possible, not this question was clear cut. When
Mhm.
possible, collect more evidence before you
Sure,
immediately
of course,
reporting. Okay.
if possible.
Is 10
Okay,
minutes
thank you.
good with everyone?